I'm Benjamin Levy. I'm an associate professor at the Johns Hopkins School of Medicine, and I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So very broadly, staging for lung cancer is based on what's called a TNM staging. A T is the size of the tumor. An N is where the nodes are, or the nodal involvement, and M is where the metastases are is there presence of metastases. And very broadly, based on the TNM staging, patients can have a stage 1 through 4. And I always tell patients, you're not a stage, but when I'm looking at how to treat you, we have to factor in the stage. And you know, I don't want to get too detailed into the TNM staging because it is quite complicated, and you can look online to all the subsets of T's and N's that exist. But the bottom line is, if you have a tumor that is localized to the lung, that is generally without any nodal involvement, that is generally, or regional nodal involvement, that is generally a stage 1 or 2. If you then begin to have a localized process or tumor of the lung with regional nodes involved, that generally is a stage 2, sometimes a stage 3, depending on the size of the tumor. And then if you have nodal involvement, what's called the mediastinal nodes, which are the middle part of the chest, that generally gives you a stage 3. Anything beyond that, a patient with not only a tumor with mediastinal nodes, but also any other organ involved, is considered a stage 4. And again, I try to steer away from patients being called a stage, but we do have to look at stage as it relates to how to best treat them. We know that patients that have a early stage or stage confined to the lung, oftentimes that dictates the management, and oftentimes that's surgery. Patients who have a more advanced stage with like stage 3, these patients are a very heterogeneous group because there's both stage 3A and stage 3B, but these patients are generally managed differently, and surgery may or may not be in play. Oftentimes these patients get concurrent chemoradiation. And then unfortunately, the most common stage for patients is stage 4. Most patients, roughly 65% of all lung cancer patients, 65%, present with advanced stage disease. So this is the most common patient that I see. And again, that does mean that the tumor has left the lung and moved to either the other lung or other organs that can include the brain, the adrenal gland, the bone, the liver. Those are the most common places that lung cancer does like to go, but that would identify a patient with stage 4. So in summary, the TNM staging is what we use. It's a pretty robust calculation. T is again tumor size, N is nodes involved, and then M is the presence of metastases or not. The T stage goes from T1 through 4. The N stage goes through N1 through 3, and then the M is just metastases or not, at least the way that I perceive metastases. There's an M1A and M1B. But again, this all comes together to calculate a stage 1, 2, 3, or 4. Regional nodes usually mean hilar nodes. These are nodes that are localized close to the tumor, that are surrounding the tumor, that are in close proximity, and these are generally called hilar nodes. Nodes that are considered to be more distant include mediastinal nodes, other nodes on the other lung, that the cancer may have moved to the other lungs, at least the nodes on the other lung, are supraclavicular or cervical lymph nodes. These are nodes above the clavicle or in the neck. These would be considered more distant nodes, as compared to more regional nodes, which are nodes that are very close by to the tumor in close proximity, which are generally removed together with the tumor if surgery is considered.